Let's dive straight into step 2 CK Next Best Step logic. We're zeroing in on exactly how to manage critically ill or complex patients, focusing purely on those exam-facing diagnostic branches and triage protocols.
We're breaking this down into 4 clinical shifts today: the emergency bay, the pediatric clinic, the neurological ICU, and finally, the psychiatric emergency.
All right, shift number 1, the emergency bay, trauma and resuscitation.
Okay, picture a trauma patient rolling in with hemorrhagic shock. Your first move, limit crystalloids to about 1 liter max. Why? Because you absolutely want to avoid dilutional coagulopathy. You've got to switch to blood products early. Now, the test loves to ask about the specific triggers for the massive transfusion protocol. That's your 1-to-1-to-1 ratio of fresh frozen plasma, packed RBCs, and platelets. You need hitting at least 2 of these 4 triggers: a systolic blood pressure of 90 or less, a heart rate of 120 or higher, a positive fast exam, or a penetrating mechanism of injury. Hit 2 of those and you immediately initiate balanced resuscitation. No hesitation.
Now, what if you need emergency fluid resuscitation, but peripheral IV access completely fails? Your immediate next best step is intraosseous, or IO access. Usually you're going right for the proximal tibia. But wait, before you drill, scan for the strict contraindications. This is a classic exam trap. You cannot place an IO line if there's an overlying infection, like cellulitis, right at the site. You also can't do it if there's a fracture or a previous IO attempt in that specific extremity. And lastly, look out for conditions involving bone fragility, like osteogenesis imperfecta. If all those are clear, drill the IO and get those fluids going.
Moving on to shift 2, the pediatric clinic. We're focusing on GI emergencies and milestones here. Let's look at a classic presentation. You've got a neonate, usually under a month old, who suddenly develops bilious emesis and a distended abdomen. Stop right there. This is a surgical emergency. You're looking at the textbook picture of malrotation with midgut volvulus. Pathologically, what happened here is the normal embryonic gut rotation failed, leaving a super narrow mesenteric base. That narrow base lets the small bowel just twist right around the superior mesenteric artery. If you don't catch this quickly, it leads straight to gut ischemia, necrosis, and shock. So remember, bilious emesis in a neonate equals an anatomical obstruction until proven otherwise. So how do we confirm it? Well, if the neonate is hemodynamically stable, the gold standard diagnostic test is an upper GI series. When you push the contrast, you're looking for that classic corkscrew appearance. That visualizes the twisted small bowel right there in the duodenum, confirming the midgut volvulus. But here's the absolute critical distinction you have to make for the exam. The management pathway depends entirely on the patient's hemodynamic status. Like we said, stable patient with a normal rectal exam, get the upper GI series. But what if that neonate is unstable, meaning they're hypotensive, tachycardic, or they have a firm peritonitic abdomen? In that case, do not wait for imaging. The next best step is an immediate exploratory laparotomy. Sending an unstable patient to radiology is a trap. It drastically increases the risk of mortality from bowel necrosis. Let's switch gears to endocrinology. When evaluating precocious puberty, which means secondary sexual development in girls under 8 or boys under 9, your absolute first branch point is checking the bone age. If the bone age is advanced, your next step is checking the basal luteinizing hormone, or LH. A high basal LH, that points straight to central precocious puberty. But if the basal LH comes back low, you're not done. You have to do a GnRH stimulation test. If the LH stays low after stimulation, you're dealing with peripheral precocious puberty. But if it spikes high, boom, you've confirmed central precocious puberty. Okay, so you've confirmed central precocious puberty. Before you even think about starting a GnRH agonist therapy like Leuprolide, there is a mandatory 4-step workup. You literally cannot skip these. Step 1, check FSH, LH, and sex steroids. Step 2, do the GnRH stimulation test. Step 3, get a CNS MRI. Why? Because you have to rule out any space-occupying intracranial lesions that might be driving this early puberty. And step 4, check thyroid function to rule out hypothyroidism. You've got to clear all 4 steps. Time for our third shift, the neurological ICU, cognition and brain death. Imagine an older patient presents with altered cognition. Your first diagnostic branch is figuring out if it's delirium. You rule this in or out using the confusion assessment method or the CAM criteria. It's pretty straightforward. The patient must have an acute onset and a fluctuating course of symptoms, plus an intention. Those 2 are mandatory. On top of that, they need to show either disorganized thinking or an altered level of consciousness. Once you diagnose delirium, you've got to play detective and systematically hunt down the underlying cause. Check for infections, metabolic derangements, or offending medications, especially things like opioids or anticholinergics.
Now let's talk about end-of-life determinations, specifically comparing cardiac death to brain death. Pay really close attention to the respiratory assessment here because the exam loves to test this. In cardiac death, where irreversible asystole has already happened, apnea is universal. You don't need to formally test for it. But brain death, that's a totally different story. The heart is still beating, but brain and brainstem activity are completely gone. Because of that, diagnosing brain death requires a formal apnea test to definitively rule out any residual brainstem function.
And the clinical prerequisites for a brain death diagnosis are incredibly rigid. Before you even touch the patient to check brainstem reflexes or do an apnea test, you must have neuroimaging evidence of a devastating CNS event. And you absolutely must exclude any confounding conditions. You cannot diagnose brain death if the patient has severe electrolyte abnormalities, if they're intoxicated, or if they have paralytics on board. Also, their core temperature has to be above 36 degrees Celsius, and systolic blood pressure must be over 100. Only after you've eliminated all those confounders can you actually verify the absence of brainstem reflexes and the lack of a respiratory response to a PaCO2 greater than 16. Our final shift: the psychiatric emergency, safety, consent, and mood.
Managing suicidality always follows one of two distinct pathways, and it all comes down to imminence. If the threat is imminent, meaning the patient is actively voicing intent, they have unmanaged risk factors, or family members are raising major collateral concerns, your priority is safety. This means immediate hospitalization, involuntarily if you have to, and starting one-to-one constant observation. Now, if it's a non-imminent risk, say there's no active intent and the patient has a really strong social support system, the next best step is creating an outpatient safety plan, making sure you remove access to potential means like firearms, and setting up very close follow-up.
Let's look at a super high-yield scenario, testing consent and ethics. You have a 17-year-old patient who comes in with active suicidal ideation and absolutely needs to be hospitalized for their own safety. Obviously, the parents need to be informed. But here is a clinical question. Is parental consent legally required to admit this minor to an inpatient psychiatric unit? Actually, the answer is no. Now, sure, getting parental consent is the ideal scenario, and we should always encourage the patient to involve their parents, but it's not a legal barrier to care. In most jurisdictions, there's a specific minor consent exception. It allows minors who are 16 or 17 to consent for themselves when it comes to inpatient psychiatric hospitalization. And here's the kicker: if that minor consents to the care, their confidentiality regarding protected health information has to be legally maintained. Next, let's distinguish between normal bereavement and a major depressive episode. Both are going to involve sadness, sleep issues, and deep feelings of loss. But here's the key difference for the boards. A normal grief reaction usually hits in waves, often triggered by reminders of the person they lost, but the patient's daily functioning stays relatively intact. However, if they start expressing severe feelings of worthlessness, intense self-loathing, or active suicidality that isn't just a fleeting thought of wanting to join the deceased, that crosses the line into a major depressive episode. And remember, even if it happens right in the middle of grieving, a major depressive episode requires active treatment like SSRIs or CBT. Let's quickly rapid-fire some high-yield psychotherapy associations. If you have a patient with depression that's heavily tied to current relationship conflicts, interpersonal psychotherapy is your gold standard. Dealing with borderline personality disorder, dialectical behavioral therapy is the specific indication there to help improve emotion regulation and cut down on self-harm. And if you're seeing prominent physical symptoms or pain disorders, biofeedback is the way to go to help them control their physiological reactions to stress. Matching the right therapy modality to the pathology is exactly what they want for your next best step. Finally, let's lock in a definitive clinical axiom. We talked earlier about protecting adolescent confidentiality, but there is one hard, unbreakable exception. You cannot promise and you cannot maintain confidentiality if a patient is determined to be at a high risk for self-harm or suicide. At the end of the day, preserving a patient's life will always supersede their privacy. Keep that rule firmly in mind for the exam, and you'll be golden.